Good morning, everyone. Thank you. Thank you for the kind introduction. And it's great to see you all. So, great topic, Dr. Varun. Thank you for making my job easier. So, yeah, following this, we can say subclinical hypothyroidism, a disease or a label, whether to treat or not to treat, you can keep on going. Let's first go ahead and see what it is. It is a definition. By definition, it is just a biochemical label. Or you can go like pre-disease state, like pre-diabetes, that can become eventually a full-blown or overt hypothyroidism. Now, how is it defined? Defined by elevated thyroid stimulating hormone levels, anywhere between 4.5 to 10, and with normal free thyroxine levels. That's the definition. So elevated TSH with normal T4 levels. Often present with fewer or no symptoms. Mostly it's an incidental finding. Prevalence in India, it's about 6 to 15%. Often common in older women, older adults, and high iodine consumption areas. So SAH is a disease or a label. How do you do it? How do you differentiate? So it depends on the severity of the label, lab results, that is where the TSH is, the presence of symptoms, goiter or TPO antibodies, patient's age, it's very important, this category. Pregnant status, infertility status, or patients undergoing artificial insemination, associated comorbid conditions. So before going into the differentiation, so what are the causes that can elevate TSH? Here, Varun gave you a big list, I'm giving you another list. So the most common is, of course, autoimmune Hashimoto's thyroiditis. So the rest already Varun went through this, but physiological causes, you should be really aware of diurnal causes, recovery phases of euthyroid sick syndrome, recovery phases of subacute painless or postpartum thyroiditis. And the most other important thing nowadays is hair loss and biotin. Please ask the patient whether the patient has seen a dermatologist, was or is taking biotin before you interpret that result. So, and rest all, if of course the other causes that can elevate the TSH. So first let's see whether it's a disease. If the TSH is consistently greater than 10, then even if the patient is asymptomatic, subclinical hypothyroidism is considered. Along with that, it is a disease, definitely. The patient needs to be treated, but if the TSH is in the gray zone of 4.5 to 10, that's where the problem comes. If the patient has positive anti-TPO antibodies, that's significant. Presence with minimal symptoms of goiter, is pregnant or has infertility issues or on treatment for infertility or has other comorbid conditions, especially cardiovascular comorbidities. So what is the phase? Exactly, again, like diabetes, thyroid also has a phase, normal phase, euthyroid. And there is a subclinical phase where only by blood test you will pick it up or incidentally you will pick it up. So where the TSH is in the upper normal to the high normal we call, or high abnormal, that is 10 and just 10, but the T4 results are within the normal limits. And this is the most important thing is I would like you to look at the bottom part. Up to 60% of the cases revert over 5 years to normal euthyroidism phase. But then 1 to 5% of the cases progress to hypothyroid phase, and especially if the antibody testing is positive. And remember again, in general population, 10%, up to 10% of autoimmune antibodies are normal, they are not abnormal. So how do you interpret the results? So some of the etiologies here, the etiologies where we call it a transient phase, which again Dr. Varun went through, transient thyroiditis or any treatment related to thyroid diseases or thyroidectomy and or any other medications. As Varun beautifully said about amiodarone and the latest ones, immune modulators, or progressive causative factors like autoimmune or infiltrative diseases. Then again, non-related to thyroid disease, again transient and non-progressive causes. This is again very important. One thing is CT iodine overdose, please remember that. Lithium has now become a favorite of the psychiatrist, It has come back into popularity. And market obesity, as we know, we had the beautiful talk yesterday, and non-thyroidal diseases like chronic kidney disease. So what are the key conditions that mimic hypothyroidism? This is my favorite discussion. So when the patient comes in here, please remember these conditions that mimic hypothyroidism symptoms. First, iron deficiency anemia, a female or a child. Please remember that. An elderly female, menopause or perimenopausal. An obese person, sleep disorders or chronic insomnia from mental disorders or clinical depression. And very common undiagnosed, underdiagnosed, or patient refuses to accept or acknowledge is depression and anxiety disorders. It is going to be a very difficult convincing the patient it's not thyroid, it is mental health issue. So then other autoimmune disorders, endocrine glandular diseases, and fatty liver. So long-term complications. So here's the next step that we are entering. If this is a disease, do I need to treat? The patient is asymptomatic. Why do I need to treat? There are studies repeatedly have proven, especially cardiovascular issues, if the patient is high risk for cardiovascular issues, 40% mortality if their hypothyroidism, even if it's in the subclinical phase and not treated. And the progression to overt hypothyroidism, then metabolic disorders, mental health disorders, physical dysfunction, obesity, reproductive disorders. We know our obstetricians, gynecologists here deal with it day in and day out. Thyroid is their favorite. I think one of the most favorite and repeated testing that they do in all their patients, and which is clinically indicated in many of the conditions. And pregnancy complications, we know, birth and developmental issues and losing pregnancy. So in case then, what are the factors favoring levothyroxine therapy? When do you start the therapy? So if your TSH is 2 times upper limit of the normal, that is, or greater than 8 here, actually we say greater than 10, it's progressive, it's rising, you're repeated. There is a positive goiter presentation or antibodies greater than like 300 or 500, you see not antibodies greater than 50 or not antibodies greater than 100. Please do not treat. And infertility, ovulatory dysfunction, or the patient is planning for infertility treatment, childhood or adolescence, especially in the pubertal phase, and other comorbid conditions, it's very important. So we do have a beautiful algorithm. I simply love this from American College of Primary Care Physicians. It's beautiful. So if the TSH is normal and elevated with the normal free T4, what do you do? Plus, first thing, please recheck the thyroid function test. How many of you do it? I know the patient is going to complain. It's their money. I won't blame them. என்னங்க மேடம் இப்பதான் எடுத்தேன் திரும்பி பண்ண சொல்றீங்க இதை வச்சே நீங்க பண்ண முடியாதா நான் தான் இவ்வளோ சிம்டம்ஸ் சொல்றேனே. Unfortunately, you have to confirm before you commit this patient to a diagnosis. As Varun correctly said, this is just a symptom, presentation. It is like fever. Until you confirm the diagnosis, you can't commit this patient to a diagnosis and commit this patient to a treatment. So it's important to repeat the TSH, usually within 8 to 12 weeks. If the patient is very anxious to know what it is, at least take 4 weeks and please repeat it. And at the time, add the antibody testing. If its antibody is negative, you can monitor, convince the patient, try to look for other causes. If it's positive, please proceed with thyroid function, and we'll check, because if the patient is asymptomatic, again, no goiter, you may not necessarily need to treat, and patient will be happy. And many of my patients are willing to be monitored. They are willing to come in every 6 months for monitoring. If the TSH remains elevated and with symptoms, again, we go down the line. If you have TSH less than 10, normal free T4, and again, you divide it between 4.57, no treatment, consider monitoring every 6 months. If it progresses, then consider 6 months, and the age, here's the age factor I said. It's very important, less than 70 or cardiovascular risk factors or very high TPO antibodies, you may consider treatment. Then going on greater than 10, definitely ages less than 70, recommend treatment, because there is a very strong relationship between subclinical hypothyroidism untreated with cardiovascular outcome, bad cardiovascular outcome. Greater than 70, please, you can give a trial, be very careful, start low, and titrate slow. So that's very important. You don't want to give a heart attack to this patient. And TSH remains elevated, symptoms of hypothyroidism. The last column, this is all in a non-pregnant adult patient I'm talking about. So 6 months trial you can give if the patient is very adamant about it. Ultimately, it's the patient who decides. It's not the doctors. Yes, you can convince, you can show the evidence, but ultimately the patient is coming with ChatGPT saying, I do have this. I am entitled for my thyroid hormone. I would rather give the patient 12.5 micrograms of thyroid, which is very safe. Nothing will happen to the patient. Say to the patient, let's give a trial for 3 months and come back and see if it's not improving, then it's not thyroid. It was other symptoms. We have to look for other symptomatology, other causes for your symptomatology. So it's very important. If it improves and the patient is happy, I'm happy, discontinue and observe the patient. So no harm. Do no harm is so important, very important. And over-treatment of subclinical hypothyroidism, we repeatedly see this patient had been started for some reason 25 years ago on thyroid hormone. Nobody dared to stop the thyroid medication. And you know what? The amount of thyroid hormone they're on, 25 micrograms for the past 20 years or 25 years, or 50 micrograms. Definitely an overt hypothyroidism or a progressive hypothyroidism, minimum dose replacement will be 75 to 100 micrograms where the thyroid has failed. You know it is a permanent hypothyroidism. So be brave as a clinical physician to cut back or stop and see. Ask the patient to come back in 10 days. That's all is needed for this thyroid hormone to get out of the system and repeat the TSH and see where the patient is. And again, you can continue to monitor to see whether the patient relapses or not. So age matters. It's commonly found in older adults over 65 where slightly higher TSH levels, where the disease label to this group leads to overtreatment. Consensus about infertility, it's very important. I really respect the docs here. Hats off to them. They're doing an awesome job of our obstetrician and gynecologist, our reproductive fertility specialists. They are on dot, and if the patient is greater than TSH greater than 4, please go ahead, start treatment, especially if it's positive with antibodies, definitely start the treatment. Goal here to keep it less than 2.5. If the patient is pregnant, definitely start because we all know the negative outcome to the fetus and the negative outcome during pregnancy. What about children? I'm an adult endocrinologist. I have touch base here. I do treat, but I cannot claim that I am an expert on child like Varun or Dr. Kumaravel. So here is the initial approach, watchful waiting. So TSH often normalizes, especially in children in idiopathic subclinical hypothyroidism. Varun beautifully said all these other I went to treat greater than 10, again goiter. Pretty much the same thing as adults, children, it applies. One thing that I always monitor very closely is the patient with Down syndrome or type 1 diabetes. Please evaluate thyroid function yearly, whether they are presenting with symptoms or without symptoms. It's very important. Monitoring frequency is important. During puberty, that is very important. Now, when do you call it a label? Transient cases, that's exactly what Varun said. In many cases, up to 50% within 2 years, they actually resolve, even with 6 to 9. Even patient greater than TSH of 100, we have seen, we have treated and the patient has completely resolved and reversed. So when you have a profound hypothyroid patient could reverse, here again, this can be a transient one. So don't be very fast to write the prescription, please. It's probably a snapshot or probably a first warning shot of the possible cause that the patient may fail. Like in a young woman who's getting married and she's going to have a kid, and you see this happening, it's better you give the patient a warning, hey, if you get pregnant, please come and see, I need to check your thyroid as soon as you're pregnant. That's where I would use this. Again, age matters, as I said, especially over 80, be very slow to start treatment or give the label. So traffic light, red. When do you really do not take any actions at all? In an asymptomatic non-pregnant adult, do not even screen. Please do not even screen. If the patient is asymptomatic, no complaints. Why do you want a TSH? Unfortunately, we have these packages being done. And that's how these incidental TSHs are found. elevated TSHs without anything. Do not order an ultrasound unless otherwise the patient has an indication. Do not repeat. There's no need for repeat antibodies. Anti-TB antibodies is an entity. What is the cause? You're going to confirm. That's it. There are a few reasons where if the patient has a goiter that's not subsiding, it is continuing, the patient is not, a rare condition where endocrinologists, we do repeat to see whether the patient is responding. Or for me, in my practice in India, even though they're paying out of pocket, my patient wants to know the antibody level has gone down. That's really, it's very difficult to convince a patient. It may or may not. It may take a time period of 10 years before your antibody level goes down. It's the most important thing is to keep your TSH at the right range. But they're willing to spend, patient has the right. So we have to order. So do not treat subclinical hypothyroidism with T3. T3 is available in India. Please do not do it. You are going to end up putting the patient in risk, especially atrial fibrillation. Under specified circumstances, consider a trial of treatment. Already I went through this. Hypothyroidism, positive antibodies, cardiovascular risk factors, specific risk factors, iron treatment, or surgical, pre-surgery. That's one other areas. Take action. Definitely, these are the ones that I would recommend trying. At the end, patient does have the right to even ask. In that case, if you are unable to convince, use the lowest dose for shortest period, 6 weeks or not more than 3 months, and please withdraw the thyroid hormone. So this is a great one. So subclinical scenarios, few scenarios I'm going to say, not as extensive as Dr. Varun. 8-year-old came with elevated TSH of 7.5. Why was it done? The mother had hypothyroidism. So she wanted to know whether a child has it. So she already did the test and came to me. No symptoms, no goiter, milestones fine, weight fine, height fine. I said, let's repeat the test. It was 6. I said, forget it, come back in 3 months or 6 months, we'll repeat. Done deal. So next, 14-year-old female. So she was consulted for, again, 7.5, lab test was done because the patient didn't achieve menarche. We can wait up till 16 years, but in here, India, the social pressure to have the first period is unbelievable. It's really a shame. The child is ashamed, and it's a stigma if you don't get your periods by age of 12. It looks like that. Asymptomatic, no goiter, secondary sexual characters fine, breast stage standard 3, weight fine, no family history of hypothyroidism. What did I do? I just said nothing needs to be done at this point. Patient still has time. The mother, when I achieved menarche at 14, we can wait. Her LH-FSH levels were right there. I said in 6 months, if the patient does not achieve, or in this year, we will consider treatment. We'll also do serial TSHs. Mother was happy. The child was happy. The child got her periods in 3 months. TSH went back to normal. So this was a physiological race before her puberty, actually. So a 15-year female child consulted for elevated TSH, again 7.5. It's the round off number. The patient hasn't achieved menarche, but she was rapidly gaining weight. The mother was very upset about it, almost like 5 kgs in 3 months, and noted acne. She started growing facial hair. 15-year-old 10th grader for the past 1 year was sitting on a butt and reading and studying, nothing else she was doing. Or just she was sitting there eating and reading and studying for exams, stressing out for her exams. All her secondary sexual characters were fine, absolutely otherwise fine, central obesity. Mother had history of hypothyroidism during pregnancy. So further workup, she has PCOD, not hypothyroidism. So when PCOD was corrected, patients lost the weight, everything went back to normal. So the last 2 cases, 18-year-old female child, TSH of 10, menarche at 12, test was done because of irregular period. Patient just went to the hospital. She started, and she looked pale, thinning of hair. She was mildly tachycardic, no goiter, milestones, everything absolutely fine. What did I do? Let's check your CBC. She was very anemic. All I did was correct her anemia. Everything went back to normal, said we'll repeat your TSH again in 3 months, we'll just monitor. She was absolutely fine. And out of stress, away from home, not eating. A 24-year female consulted for infertility treatment with 7.5 with the antibodies negative. though this was a consult given to us, and we did start this patient because she was undergoing, because from American Obstetrician Gynecology Association and rest of the organizations, Indian organization also considers TSH of 2.5 if you want to do infertility treatment. So final, 80-year-old, I just want to skip on. The next one is a menopause case. Again, was a subclinical, nothing to do with thyroid. The last one was 80-year-old who had 4 years of subclinical hypo, went from anywhere but 5 to 8. We thought he had issues and everything, but ultimately it was a mild case of Parkinsonism and other things, age-related changes, was absolutely fine, and that was my father who passed away 3 years ago. So here we go, summarize. In summary, elevated TSH with normal free T4, chronic autoimmune disease, manage, watch and wait. Please, treatment recommendations, again given, I'm not going to go over. Progression is a low risk of progressing to overt hypothyroidism. Please watch and wait. These are the acknowledgements, and thank you. Thank you for this opportunity.